Hello, just checking my audio. Hello, hello, hello. Okay, great. Audio check is correct. Hi, everybody. My name is Marcel Brus-Ramer. I'm going to be leading this webinar. We're going to get the slides up in just a second. I'm going to turn off my video. I'll keep my audio on. Also, for those who are just checking in, we have a chat function, Q&A, and we'll have some live polling to help make the presentation a little bit more lively. Just checking one last slide. Just a second. Hi, everybody. My name is Marcel Brus-Ramer. I'm just getting our slides up, and we'll get started in just a minute for the webinar. Okay, I'm going to set up I'll share my slides now. Show you guys who I am. Hi again, everybody. Thanks for joining. My name is Marcel Brus-Ramer, and I'm going to be sharing my screen. We'll do the webinar. Oh, I need to put this in presentation mode. Just a second, and we'll get going. Everything we're doing today will be recorded. A set of the slides and a recording that will be available, and I'll tell you where to find those. If you're interested, you can share them. And again, thanks for joining in. Okay, we're going to be doing some live polling throughout. Hopefully you can see that at the bottom, the link. It's on Poll Everywhere. I like to use this whenever I do presentations for other stuff, USMLE. As you can tell, I did this presentation yesterday at 3 p.m. Eastern and today at 6 p.m. And you guys are here for the second presentation. So thanks for joining in. Let's get started. Okay, so just a little word about myself so you know where I'm coming from. I'm a MD PhD. I studied at Columbia and then did my for medical school, and then I did my radiology training at UCSF and did neuroradiology fellowship. So I'm not a chest radiologist, and I think that that's important to bring out in front. This is not designed to be a high-end radiology level, presentation for other radiologists. This is trying to be a presentation for those of you who are not radiologists, who are just trying to get a basic handle on what's going on with COVID. And I think that it's kind of maybe useful that the fact that I'm not a chest radiologist, because I won't dive into too much of the details of the disease process, the nitty-gritty and some of the esoteric stuff of the imaging. But I do want to show you some of the basics and some of the stuff I've seen and some of the sort of ways of thinking about this that I've been using when I do radiology interpretation. My background currently is that I work as an emergency radiologist for a group that covers hospitals across the Southeast, Midwest, and even the West Coast. I've seen a lot of COVID cases. I've been to several CMEs online for this, so I've gotten information from colleagues who are specialists and also just sharing with other colleagues. I also do work in education related to boards preparation, step 1, step 2, et cetera, and also with other board exams such as ABIM, and that's through the company Elite Medical Prep, and that's probably why you saw an address when signing up that it was Elite Medical Prep. I've just borrowed our webinar capability and used that for this presentation, so I wanted to give them a thank you for that. Okay, so enough about me. Let's get to the actual presentation. The goals for today are as follows. 1, familiarize yourself with COVID-19 appearance on imaging. This is not to say you're going to do the interpretations or write final reports, but you may be in a busy hospital, or you may not have gotten the report, and you may want to take a look at the scan or the X-ray image and get a sense of what's going on. It's also just good in general to be a good doctor, to be familiar with this major health health crisis, this pandemic, and imaging is going to be a key part of it. We're going to talk about some basic chest imaging anatomy and some descriptors. We'll sort of try them out ourselves. We're going to familiarize ourselves with other causes of dyspnea and fever. So we need to think beyond just COVID. Remember, not every patient that has shortness of breath is going to be a COVID patient, although a lot of them are these days, and everybody's concerned about it. We're going to consider the imaging options, and then I have some simple takeaways. And those takeaways are going to be, I'll give it to you up front and at the end. And I think that that's important because this will be sure that if you lose an internet connection or you have to step away, you'll have gotten the basic point. So let's talk about the takeaways. Okay, so what are the takeaways? This is a kind of a busy slide. We're going to go through this in parts, but I'll show it to you up front and I'll show you to this again at the end. Basically, we have our COVID column and our non-COVID column, and I think that's important. Most of you guys are familiar with what the symptoms are for COVID. If you've seen any patients, or if you've not, and you're going to the hospital, you'll see patients soon enough, and you'll become familiar with them. Okay, what we're going to mainly focus on are the imaging appearance, and we're talking about the ground glass opacities, the peripheral nature of them, how they're bilateral and tend to be in multiple lobes. We'll talk about how when that progresses, it becomes more consolidations and has I use the term crescentic, but peripheral as well, and how they can become more diffuse and look even like ARDS. We'll also talk about what's not seen in it, which is essentially effusions, airways thickening, and septal thickening, and we'll get to that. And then the imaging choices we'll discuss and we'll go over. And of course, I'll be happy to answer your questions. But the bottom line is X-ray is insensitive, but pretty good for monitoring. But really, the way we're going to make our determination is with chest CT. And then the details of whether to use non-con or CTA or CT chest with contrast, that's sort of separate. But chest CT in general, any form would be fine. There are non-COVID things non-COVID diseases we'll be talking about: influenza, bacterial pneumonia, bacterial pneumonia, pulmonary edema, and PEs. These are not everything that we'll talk about, and these are not everything that you might see on a chest CT, but these are the kind of things that you should be familiar with. So it's important for you guys to have a little bit of familiarity, particularly if you're going to be going into the wards now. And this is good just for future reference. Okay, before I move on, just want to double check if everybody's okay and everybody has found the audio good to this point. And then if there are any questions, more details of this presentation. I'm going to open up the poll everywhere slide, and I'll show you that again in a second. Launch that. Okay, so I have poll everywhere going, and it should be clear the responses. Okay, great. So if there are questions, just put them into the chat box. Please feel free to ask throughout, and I'll be happy to answer any questions that you might have. Let me just put this over here. Okay. And if somebody would just mind giving me a thumbs up if we have good audio. Okay, great. Thanks so much. Appreciate that little shout out. Usually I have somebody else to help me out with these presentations to be sure that there's no problems. Okay, let's go on. So COVID imaging timeline. Basically, we have a bit more words, and then we're going to get mainly to images the rest of the way. I don't like slides with lots of images, but I think these are important. Okay, for most people, 0 to 2 days is called the acute phase, and about 50% have normal chest CTs. So if someone just has symptoms started 24 hours ago, the likelihood that you're going to see something on chest CT is about 50-50. So it's a good question whether you're going to look for that. There are findings in some people, in about a quarter to a third, there are ground glass opacities. So we'll put that to the side for a second. Intermediate phase, that's about 3 to 5 days from symptom start. And at that point, we're going to start to see imaging findings and much more likely to see the ground glass opacities. And the late phase, which is 6 to 12 days, and seems to follow the description that we're hearing from people who've recovered, is that the disease takes about 10 to 14 days to recover from. There's a progression of the ground glass opacities to become more consolidation, and then there's a possible sort of fibrotic response that occurs afterwards, and even like reticulation. But that's a later thing, and at that point, we're not really going to be doing imaging because we'll have already known that the patient is positive for COVID, probably via testing. We know that there's a description that there are GI symptoms, so people have loss of appetite and diarrhea. The loss of appetite may be related to anosmia, basically loss of sense of smell. That seems to be a very, very early sign in COVID. And so there's also another hallmark that you should look for is that patients sort of show up and have shortness of breath while doing routine activities. It's kind of the same way that I remember hearing described cardiomyopathies in younger patients. they feel tired, but the real extent of their cardiac damage and their shortness of breath is not really elicited until you have them walk down the hallway of, say the cardiac unit. So when a patient starts to walk around their house, that's when their shortness of breath may be exacerbated. If they're sedentary, they may never really notice how short of breath they really are. Okay, so just as for some clinical points. I mentioned the word ground glass opacities. I'm going to do this throughout. I want to define what these things are. Ground glass opacities are sort of a grayish appearance it's basically a way of saying increased attenuation or increased density on lung CT, but you can still see the bronchovascular markings. I mean, you can see the airways and the little vessels through that density. So it's not totally whited out, as you might see. And this is an example of ground glass from, I think, from some beaker or something. Okay. There have been a couple of reports, been lots of reports in the academic literature. A couple of the major ones have come in the journal Radiology, which comes from the RSNA. And this initial one that came from the 27th basically reiterated what I said before about the 50% normal CT scans at 0 to 2 days. The other thing that came out is that initially, and this may still hold, RT-PCR may be have a sensitivity as low as 60 to 70%. So that's important that PCR, at least some of the early PCR testing and some available at certain hospitals, may not be able to pick up the disease. Additionally, early course of the disease, we're seeing that there are peripheral ground glass opacities, we said that early phase, in about 50 to 75%. So there's pretty good sensitivity, and we'll get to that subsequently. When the disease progresses, there's something called crazy paving. And the reason I bring this up is not because I want you to learn it, but because you should be familiar with this term. This is a radiology term that we use. There's also some consolidations that we mentioned, and these tend to become the dominant findings. It's sort of a evolution of the initial appearance. And per this report, it said it occurred at 9 to 13 days. So there's a kind of an overlap. And of course, they said that this stuff appears to clear at about a month and beyond. Now, what is crazy paving? Just so you know what that term is, it's ground glass opacities that then have superimposed lines around them. We'll talk about this in a second. These are called interlobular septa, or the edges of the pulmonary lobule. We'll talk about this in just a second. And these things can get thickened. And this appearance is totally nonspecific, but it seems to be seen with cases of COVID. Okay. It's also seen, of course, with a lot of other disease processes, but it's something that you may hear, and so I want you to be familiar with it and understand that it's just not out of nowhere. Okay. There was another report that came out from Rome, Italy, and I think this report is really, really important because it sort of reflects apparently what's going on in what happened in Italy. It reflects a lot of what's been happening in New York City. The curves have been matching, and so there's a thought that the disease process or whatever, if there is a different version of the disease or a different mutation of the virus, that version, whatever's happened in Italy has happened also in New York. So maybe it's because of similar populations or whatnot. So this report is quite important, I think, for helping us to predict what's going to happen and how we should manage it. What we notice here in this report is that some of the bottom lines, the sensitivity of CT for COVID was calculated at 97%, and the reference standard was RT-PCR. Specificity wasn't as good, but importantly, it was very sensitive at picking it up. Additionally, these authors found that in people who are positive by PCR for COVID, 100% had ground glass opacities, and 93% had multi-lobe or posterior lung involvement, and 91% had bilateral pneumonia. So what we should be thinking about is ground glass opacities, multiple spots, multiple lobes, both sides. That's kind of our takeaway, and I think I showed that at the beginning, but I want to reiterate that. There were some mentions of a subsegmental vascular enlargement, but I'm not really sure what that is and I know what that is, but I'm not really certain how to put that in context, how that really adds additional information. This first line here sort of hits our bottom line in terms of imaging appearance. It's also not clear what this vascular enlargement refers to, and so it's something that you may hear, but to my mind, I would largely put aside, given that we're going to almost always see ground glass opacities on the imaging. Okay. If there are any questions, again, please feel free to input them into the webinar chat. Okay, so here we have a normal chest CT. We have our axial slice and our coronal slice. Okay, you guys are probably all familiar with this, but just to refer, this is axial slice of the chest. This is called a lung window, so it's a wide window. What that means is that we're focusing on the lungs here. It's called a lung window, we might call it. And what we're not seeing so well is the soft tissues, the subcutaneous soft tissues, the muscle, the bones, the heart, the spine. We're not seeing them as well. We're just mainly focusing on the detail in the lungs. We can re-window the CT, the same image, and we can take a look to see at the soft tissues, but we won't be able to see as well the slight changes in density that we might see in the lungs. So this is the window we're going to use when we're looking for these ground glass opacities, these very sort of low attenuation or areas. And we'll show them in just a second. It's important to remember that on the image left is the patient's right, image right is the patient's left. So this is the right side of the patient, and this is the left side of the patient. Okay, you can see the little arrows there for to help you out. We're also at the level of the heart. Okay, but we have to scan through to see these images, the appearance at different levels. Okay, and this is our coronal appearance. Okay, so let's dive a little bit deeper. So here's our normal chest CT, but if we blow this up and we use a special technique, we can actually look at these little polygonal structures. These are called secondary pulmonary lobules, okay? And these secondary pulmonary lobules can be represented on this little diagram here. What they are basically little units of the lung. And on the edge of these are the interlobular septa. I mentioned septal thickening, and these interlobular septa contain the pulmonary lymphatics and pulmonary veins. These drain back towards the heart. The center of these lobules is the airway and the pulmonary artery that come into that region. So if we think about the nature of the disease process that's affecting the lung or the heart and its effects on the lung, then we can get a sense of the distribution of where those problems are. In COVID infections, what we're finding is that the alveoli, which make up the sort of parenchyma of this pulmonary lobule, are where the effects are occurring. And that's because COVID tends to affect type 2 pneumocytes. Okay, so if you remember back to your USMLE step 1 days, you'll remember that type 2 pneumatocytes are sort of the stem cells of the lung. They help regenerate and recover from infection. They also do a lot of other things related to angiotensin formation, angiotensin 2 formation. But the idea is that the effects of COVID tend to be down in the level of the alveoli. Conversely, a process such as influenza affects bronchial epithelial cells. So it's going to affect the cells of the little terminal bronchioles and often cause them to be thickened and then potentially even blocked. And what will happen secondarily is that because they're blocked, they'll leave debris behind and form little nodules that are solid. And we'll show those. They'll be associated with the center of these lobules. So it's got kind of a pattern that fits that. Of course, if we had a pulmonary artery embolus, then the pulmonary artery embolus might affect the pulmonary artery and cause issues in the pulmonary lobule. If we have a backup of fluid in the pulmonary veins and lymphatics, and that would cause fluid to build up first in these. And then if the fluid is just too much, there will be fluid leakage into the pleural space and into the air spaces themselves and cause frank pulmonary edema. Okay, so if we just take our step back and we think about what process we're dealing with, it'll help us understand what's going on. Okay. Okay, great. So if there are questions about this, please feel free to ask them. You can also send questions to me at the end of the presentation or afterwards. Okay, so I just want to show you a gallery of some pathologic findings. I think this is important. Ground glass opacity. This is what we mean by ground glass opacity. Kind of a hazy gray, but we can still see the arteries and the vessels in the airways through that density. So it's not dense enough to obscure them. Consolidation. This is where the air spaces themselves are being filled with debris or fluid or soft tissue, or sometimes cellular material that's filling them up and it's causing them to be filled up. And usually it's in a confluent sort of area. We may see air bronchograms or not, and it's going to tend to be in a distribution that fits a pulmonary lobe or pulmonary segment. Okay, so knowing that is important. So this is a consolidation that's going to be classically associated when it's so big like this, going to be associated with a bacterial pneumonia. This is what I talked about with crazy paving, just so you know. You're not going to see it so much. You don't need to make that designation, but just so you understand what it looks like. And here's something called organizing pneumonia, which is another thing that we'll see. Organizing pneumonia is kind of a bad name in the sense it's really a pathologic name. It's from the pathology literature. What it refers to is a chronic process. So it's something that's occur a month, 2 months after an infection or inflammation. It has a consolidation type appearance, but it doesn't seem to really fit a lobar pattern. It's sort of like it's almost like a scar that occurs, but it looks almost like a consolidation. And the importance of this is not that you're going to make the call of organizing pneumonia, but that if you see that in a report, possibly organizing pneumonia as a differential, then you understand that the radiologist is signaling to you, well, to say, hey, this is what that looks like, but this could also be associated with another process. The reason why we bring up the term organizing pneumonia is because in advanced cases, progression and then resolution of COVID, what we're tending to see is organizing pneumonia or an organizing pneumonia type pattern appearing. It does not mean that the patient necessarily has that, but it has an appearance similar to that. Okay, and so that would imply, if it is organized pneumonia, it would imply that there's the right clinical history, the right imaging history, and then if they did biopsy, it would show this sort of lung scarring and inflammation that obstructs little airways. What we're going to focus on, and what you're going to see 90% of the time, or actually 97% of the time, is this ground glass opacity. So that's what you're focusing on. In COVID, we're going to be seeing different sizes and different distribution of ground glass opacity, but this is just a really good example of a non-COVID ground glass opacity. Okay, great. So let's make sure that you have your polling ready. We're going to do some active polling, and we're not going to be using multiple choice. We're going to use a different format in Poll Everywhere. So if you guys are ready, get the Poll Everywhere open on your phone, your computer, whatever device you're using. Okay, so what I want you to do is take a minute here to look at this chest CT. This is the soft tissue windows on the left, and then on the right, here's the lung windows. Obviously, if we're looking for COVID, this is a case of COVID, we're going to be looking for things in the lung windows because we're going to be focusing there. I do this, I want to point out that we see abnormalities over here. What I want you to do on the Poll Everywhere is to start typing in, you'll see some freehand, what kind of terms might be what you might represent what you're seeing here. Use some of the descriptor terms that we talked about, just for your own mind. So on the Poll Everywhere, what you can do is type in what are the words that you might use to describe the findings you see on the chest CT. Okay, great. So I see one person put some stuff in. Let's wait for some more responses. Let me show you what that looks like on here. It'll register in just a second. Okay, so here's what you're getting: consolidation, ground glass, multifocal, opacities, peripheral. Great. So you guys are putting key words in. I want you to use this process to help you think about what it is that you're seeing. Okay, even if you're not going to make the determination of what this is and write the final report, it's good for you to think this through and to do this in this way. The other reason we're not using multiple choice is because we're now in the world of real world of medicine. I'm going to show the link one more time. Just let me go back one more slide. Here's the link, and I'll copy that in for everybody. Just a second. So www.pollev.com/smartland010. Okay, so I put the poll into the poll address into the chat. Let me make sure I send it to all the. There we go. All right, everybody should have this, the polling link. Okay, let's go over to the poll and let's see what we have here. Okay, great. So I see ground glass, multifocal, bilateral opacities, consolidation, and peripheral. Okay, excellent. So I'm going to go back to this image just quickly. What I would say for this is there are peripheral, bilateral, ground glass opacities. Maybe rounded, maybe well circumscribed. I would not really say consolidation. You could consider maybe this stuff here in the lingula as potentially developing consolidation. Again, we're only looking at one image slice, one axial slice through the chest, so there may be consolidations elsewhere, but from what we're seeing, this is a ground glass opacity that's rounded and pretty well circumscribed. It's peripheral. Here's another one over here, and here's another one over here. Okay, so we're seeing bilateral ground glass opacities, and that would be that if this patient had fever and dry cough, we would start thinking COVID. Absolutely. Okay. I'm going to go on to the next one. How about this case? Here's another example. Okay, I'm going to clear the responses again. What do you guys see? Okay, so in this one, I don't have the link up there, but what we have is I have people saying ground glass opacities, crazy paving, bilateral multifocal, I see consolidation, left infiltrates. Okay, I would say again, ground glass opacities, relatively well circumscribed, maybe some patchy infiltrates. Infiltrates, sort of that patchy infiltrate word is a little bit non-specific, but in this case, what you're trying to say is that there's a disease that is occurring within the within the pulmonary parenchyma, within the air spaces. It doesn't seem like it's filling airways. I would avoid using the term crazy paving, and I wanted to bring that up because right here we're not clearly seeing clearly delineated pulmonary interlobular pulmonary septa with overlapping overlapping ground glass. So we want to reserve that term, but the fact that there's a sort of heterogeneity of ground glass is important to bring up. These patients are going to have ground glass that's sort of more faint and more dense. So we want to get used to, want to be familiar with that. So we see here there are two, bilateral and peripheral. They're in the lingula, and then we see maybe another one over here on the right in the right lower lobe. Okay, these other findings down here are going to be more probably linear densities that are related to scarring or related to vessels or airways that we're seeing partially. Okay, excellent. Let's go on here. Here's a case where I have an X-ray correlate and a CT, and again, we have another example of ground glass opacities. They're peripheral, bilateral. Again, they're quite faint, and you notice that I had to window this in a lung window to see them. If I put it in soft tissue window, would not see these at all. So really have to be sure and look carefully for this. Okay, bringing this up, you can see on X-ray that maybe you can make out an opacity here and here, but oftentimes the X-ray may be totally normal. Okay, so if you don't see the things on X-ray, that's totally fine. But on CT, you should oftentimes see it, especially if they've had 48 hours or more of symptoms. Here's another one, and this time you guys might want to add some, let's clear some responses. What do you guys see here? Okay. So what I'm seeing is ground glass opacity, consolidation, peripheral, crescentic, good, right side, what else, unilateral, okay. Good, a couple more responses. Excellent, okay. So predominantly we're seeing findings on the right side. I see something that's sort of crescentic or peripheral. It looks like it's a bit of a consolidation. So this may imply that this is more advanced disease. Okay, we see another opacity here that may be part of this process, maybe a ground glass opacity. We're just offering that up. Then we see over here another opacity, sort of peripheral, maybe sort of more denser, but kind of ground glass. It seems to have a peripheral extent. We see another one over here that's extending to the pleura. So together we're seeing bilateral, ground glass opacities, and also peripheral consolidations that are somewhat in a crescentic or linear fashion. And those findings together with the correct clinical history strongly going to favor COVID. Okay, that's especially in endemic areas, so anywhere in New York or places where I work, like say in where I do radiology coverage in the Georgia, Atlanta metro area, and some other places. This is definitely going to be a strong concern for COVID. Okay, so this is another kind of appearance you might see. Okay, great. So here's an X-ray of a patient that I read recently. This X-ray is what I call normal. Radiographically, it looks normal. I don't see any opacities. It looks like they have normal heart size. Lungs look clear. This is sort of normal appearance of the pulmonary vessels and the proximal airways. But of course, the patient was hypoxic. Oops. The patient was hypoxic. And so what did we see at different levels? So here is the lung apices. Here are sort of mid lungs, mid to lower lungs, and then down here we have the lung bases. And I will talk about what we do see and what we don't see. So what I want you to do in this one is as follows. I'd like you to write not only what you see, but also what pertinent negatives are here. Okay. So take like 30 seconds or 60 seconds to do that. Okay, great. Bilateral ground glass opacities. I'm going to go back to the slide so you guys can see it, because just give you a chance, but just want you to know, put your answers in bilateral ground glass opacities. Also put in pertinent negatives. What things are you not seeing? Okay, I have a lot of responses so far. So I'm seeing consolidation. The consolidation that I see mentioned, clearly there's some consolidation up in the right upper lobe. Okay, and that's somewhat peripheral. That is pretty atypical for a bacterial pneumonia. So this is a consolidation that would already be concerning on itself initially. We see more peripheral consolidation, almost in a crescent, along the margin of the pleura. That's concerning. Maybe a ground glass opacity over here that's peripheral as well, in the mid-lung. We're seeing things that are on both sides. So we already see disease on the right and the left. We're seeing stuff that's involving the right upper lobe and clearly looks like the left upper lobe and maybe even the apical portion of the left lower lobe. When we come down here, we see a ground glass opacity that is probably in either the middle lobe or in the base of the right lower lobe. And then we're coming down here and we're also seeing another ground glass opacity. Those are great positive findings. So bilateral, ground glass opacities, peripheral consolidations, peripheral distribution, excellent. There was some mention of crazy paving. Again, I brought that up largely to sort of expose you to that, but I don't know that I'm going to show you an example of it, and it's much less common, so don't get hung up on that. How about things that are missing? I haven't seen anybody say anything that's missing here. What important finding is missing that's usually easy to pick up? Be down to the lung bases dependently. You can throw that on here. What are we not looking for? So somebody said the word effusions, things we're not going to be looking for, no pleural effusions. So we have no pleural effusions, and remember fluid is going to go to the dependent portion. So no pleural effusions, that's good, okay? Other things, we don't see any cavitary lesions in this patient. We don't see, and we don't see segmental or lobar consolidations. We see more peripheral consolidations that don't really match that pattern. Another thing that some have mentioned is that there's not really adenopathy, but it's sort of harder to bring out. We don't see much in the way of hilar nodes. So important to say that you see the positive findings and then look quickly to see if there's anything any signs of pleural effusions. If there are no effusions, then you're likely dealing with a COVID patient. Okay. Okay, great. Let me show you what you guys put down. Over here, it'll pop up. Okay, so here are the words that you guys use, and I would include no effusions on this as an additional response. Okay, let's go to the next slide. Great. So I just want to show you what COVID looks like on chest X-ray, and you can see that there can be an advanced disease. There can be really patchy bilateral airspace opacities. You could call these ground glass, or you could say that these may be areas of consolidation. The real test for this would be doing a CT scan, but at this point we know that the patient has some kind of active bilateral disease, and if their pulmonary status suggests it, then we know that we're dealing with a COVID patient. In this case, we can make out their enteric tube. This patient has pretty extensive disease, but they have not been intubated. Okay, so just because we see all this disease does not mean that the patient is necessarily going to be intubated. Okay, chest radiography will help us determine progression of disease, but does not make our determination of who has worse disease or who's in worse clinical status. Okay, so just very, very important that you take a look at, you consider that. Here's another case we'll run through quickly. This patient has a peripheral area of consolidation. It could be almost in an organizing pneumonia type appearance, but it's probably too acute to be. There's some peripheral ground glass over here, and maybe there's some other areas of peripheral ground glass in this patient as well. So again, this is another patient concerning for COVID. Male, middle-aged. I forget if this patient had risk factors, but as the news reports have come out, it seems that males tend to be more affected than females by a 6 to 4 or say 6 to 4 predominance, if I remember correctly. Okay, let's skip across that in interest of time. I just want to show you an example of what the progression looks like, what a more advanced disease looks like. This is where it becomes very confluent. This is a patient who was a nursing home resident, had worsening O2 sats, and this patient has extensive ground glass opacities and areas of patchy consolidation. In some places, you might even make the determination of, hey, there's something that could look like crazy paving, but I would not make that determination because I don't see the clear interlobular septal lines along areas of ground glass opacity. I just want to bring this up that this is something that you could see in a more advanced case for these patients. Okay. Any questions so far from what you guys are seeing? Please submit them along the way. I'd be happy to answer them and take a moment to stop. Okay. I do want to again point out chest X-ray and how it can be used for progression, but I want to point out something here. We see 2 chest X-rays, and if we look at them carefully, the one on the left, the one on the left, and the one on the left and the one on the right, and the one on the left, I'm seeing sort of slightly denser opacities in the right mid lung, and maybe even more opacification of the left lung base on this X-ray. And while we can use it to assess for progression, it doesn't necessarily determine the patient's respiratory status. So here the patient is intubated in both cases, but the disease can progress. So it's going to be helpful. Actually, it's going to be helpful for us to figure out progression, but not necessarily to tell us how they're doing clinically. So that one was a pretty good one for progression. But here, what we see is a case where sort of the inverse. This patient has worse disease clearly on the X-ray on the right, and on the left, the lungs look clearer. What we noticed, though, is that this X-ray, I didn't put the date down, but this X-ray was done 6 days ago, and this X-ray was done 2 days ago. So there's been a 3 or 4 day difference between the two. What we noticed, though, on the X-ray on the left, which has clearer lungs, is that the patient is intubated. Why is that? The reason I bring this up is to help point out to you guys. The reason I bring this up to you guys is to help point out that patients' respiratory status can be much worse and far worse, even if their lungs are clearing up or clearing up by X-ray. So again, don't be over-reliant on the chest X-ray appearance for clinical status, but you can use it to help evaluate for progression of disease. Okay, there was a question from one of the people out there. Have there been reports of permanent pulmonary fibrosis in patients that have recovered, or any other long-term consequences in PFTs? Okay, so from what I've heard and what I've read so far, what I've heard from colleagues and read so far is that the response 1 month after the disease is that there are areas of pulmonary fibrosis that occur, and that there are scarring that occurs. So that would be a form of fibrosis that occurs after patients that have recovered. So that progression, that description of organizing pneumonia, or those areas of consolidation may reduce, but there probably will be some kind of abnormality that would occur afterwards. Additional question I think that came up from somebody is from somebody's, would you likely say this is ARDS? Okay, in this X-ray here on the right, without the intubation, this patient, if they had the correct clinical set data, then they would fit with ARDS. So I could say possibly compatible with ARDS. It is important, though, that you do not fall into the trap of calling it ARDS simply on the basis of the X-ray. Remember, the X-ray is just a representation of what is going on. It is not the reality of that patient. And ARDS is a clinical diagnosis. So do not rely on your radiologist to make the determination that the patient has ARDS. They can help suggest that the imaging could match ARDS. Again, you're gonna have to look for those clinical findings, and you should know that criteria. There are many patients who are going into ARDS with their advanced disease. Okay, if I've answered all the questions, I'm gonna move on to the next slide. Okay, last slide that sort of summarizes what we talked about before, positive features and negative features. This comes from the Italian study that I put up at the beginning. Just summarizing the table: ground glass opacities, multiple lobes, bilateral, peripheral. We've talked about this. Negative features: lack of septal thickening, lack of pleural effusions, lack of bronchial wall thickening. Okay, we'll see where these come up in other disease process next. So non-COVID-19 imaging. So what do we see here? I'm going to clear the responses. If you guys can put in responses, we're using the same poll again. Try to describe what you're seeing here. Okay, I'm going to show you guys what you're saying so far, so you can get a sense of what your colleagues are saying. Focal, lobar, pneumonia, consolidation, organizing. Okay, central, segmental, peripheral. Okay, great. These are good descriptors so far. Excellent. So I'm going to go back to the slide. Take a look at this. Okay, this is the chest X-ray, and then this is the accompanying CT on this patient. In this patient, if we look carefully and we compare side to side our chest X-ray, looking at the lungs, as we should do, looking side to side, we should see that the apices look clear, mid lungs look pretty clear. We see the vascular markings, and if we come down to here, look on the right, this is relatively clear for the right side of the lung. There's a lot of overlapping vessels here, so it can look like this is hazy. If we come over to the left side, we're kind of losing the airspace. So it looks like there's some kind of opacity here on X-ray, and I would say maybe there's a left lower lung opacity that's peripheral. do the CT scan to confirm, and what are we seeing? As you guys have described, segmental area of developing consolidation. It hasn't fully consolidated, it hasn't fully filled in yet, but it's getting there. You can see that it kind of radiates away in a pattern that would fit with a pulmonary segment, and potentially if it progressed into pulmonary lobe. If we had a thinner slice, we might even make out that there's a little bit of airway thickening here. This would be something that would probably fit with a bronchopneumonia, classically associated with a bacterial infection. We don't see bilaterality here. We don't see the multifocal ground glass opacities, although we see what fit largely with a pneumonia. An additional question that came from somebody who's listening. Sorry if I missed this, but do we know if asymptomatic COVID patients also have lung findings on chest CT or chest X-ray? Great question. I think that there probably are patients out there who are asymptomatic and have chest CT or chest X-ray. The problem is that we won't do imaging on patients we largely won't do imaging of the chest or any part of the body unless the patient has some symptoms of the disease. There's not really an not really an indication to do that. However, there are cases where we're seeing patients with abdominal pain for other reasons. We scan through the lung bases and we find evidence of early COVID disease or early ground glass opacities, and then that prompts us to do a further evaluation. The numbers on this, I don't know how we would assess that, precisely because we wouldn't image patients who are asymptomatic. Largely wouldn't image people who are asymptomatic. Okay, so great. So this looks like a consolidation, and I call this an early consolidation peripheral. There's been a question about this. How do you tell the difference between effusion and consolidation? That is a great question. I'll show you that on a subsequent slide, but I want to point out here that this consolidation is in the lung, is in the airspace. And where would the effusion be? If there was an effusion, it would not always, but likely be in the most dependent place because water is heavier than air, and the pleural effusion would end up being lower down and peripheral. It also has a different density on CT, okay, and it has a different appearance on a slightly different appearance on X-ray depending on the patient's position. Okay, so let's try to go onto the next thing. So here's the lobar pneumonia, and here's an axial image of this, and this is the coronal, and we can see the association between the two, okay? And it's in the left lower lobe. Here's a patient who we have other findings. So let me clear the responses. Why don't you guys put in your responses? And this is a totally different disease entity, and hopefully this will answer the question that was just posed. So describe what you're seeing. Great, so I'm going to show you what you guys are putting up so you can see what your colleagues are doing. Great, so I see the word effusion, large pleural effusion, right-sided, a consolidation, unilateral. These are great words so far. Excellent. Okay, so I'm going to go back to the slide and try to show you guys what we're seeing here. So again, lung windows and soft tissue windows. Notice on this, we can see the airspace of the lung very well on the lung windows, but we can't see it as well on the soft tissue windows. However, we get some additional information here. We're able to distinguish between what's going on here in the right lung. So if we go to our soft tissue windows, in this case, there's a CTA that was done. What we're getting is we see this area of consolidation. This is the lung parenchyma. It's consolidated. It's sort of patchy areas of consolidation. We can make that out better on the lung windows where the patchy areas are. Maybe some associated ground glass, but predominantly it's a consolidation. And what is this that we see? We see something that's slightly darker and slightly less dense, and that's fluid. Soft tissue is going to be denser than fluid. And then what is this dependent fluid? Oops. What is dependent fluid? This dependent fluid is going to be a pleural effusion. We can see it sort of following along the pleural margin here. So this is a pleural effusion, and it's a consolidation. What I'd probably call this is a consolidation with an associated effusion. And if I thought that the patient was infected or heard they had a fever or a white count, then the thought process here would be a consolidation or pneumonia with an associated effusion, or pneumonia with parapneumonic effusion. Okay. So for this patient, if we saw their chest X-ray, what we would see is blunting of the costophrenic angle, because what we're seeing here is we're seeing fluid filling the dependent portion of the pleural space, and it'll go to, when the patient sits up to do a chest X-ray, it'll fall down into the costophrenic angle portion of the pleural space. Okay, great. So you guys, the words you put up here were excellent. for this, just to show you again what everybody put up. Excellent. And so we'll move on to the next one. So that would be in this case, actually, it was a multilobar pneumonia with a parapneumotic effusion. The reason multilobar is because it's involving the right lower lobe and also, I think, the middle lobe. Okay, what are we seeing here? Let's see if we can. Oh, it didn't. Did that work? No. I'm gonna have to escape the presentation for just a second. Okay. I'm just gonna escape the presentation for just a second. And we're gonna get rid of this slide. Okay. And we'll share the presentation again. Okay, you guys should see this again. And there was another question. And also maybe okay, another chat. Okay, great. So what do you guys see here on this slide? I'm just going to clear the responses. And the arrows help to point out what we're looking at. Okay, so what I'm seeing, and I don't have the slide. Let's see if I go back to the slide for you guys. Back up, slide. Oops. No, don't have that slide for you. What I'm seeing in this slide, people saying patchy, septal thickening, ground glass infiltrates. Okay. See somebody mentioned airway marking airways, septal increased infiltrates. Okay, maybe bronchograms. So what I would describe this as is what we're seeing here is an area where we see airways that are thickened and little areas of solid nodules that are clustered around the airways. Now, if we remember back to what I described, what disease process attacks the airways and produces maybe nodules as a secondary response, we would think about which one, COVID or another virus. Somebody wants to put an answer in there. What if we're thinking about something that attacks the airways, not that that causes airways thickening and maybe causes second nodules as a consequence to it? What might that answer be? Okay. Somebody want to put that up? Okay, I don't see somebody putting an answer in, but I'll give you. Well, now I see influenza. So influenza is what we're thinking about here. So this is a case of presumed influenza. This patient turned out to be flu positive, but the pattern here does not match the COVID. It's not bilateral. They're not these peripheral ground glass opacities. We see these little nodules. They all seem to be clustered around an airway, and they almost have what are called a tree in bud appearance, meaning they're filling the final little airways and filling the alveoli with debris. And so this would fit an influenza pattern or a very, very early pneumonia pattern, like a bacterial pneumonia pattern. So this would be a case of influenza. Okay. In this case, I'm showing you something where we're asking a question of whether this patient has co-infection. I see what looks like a likely bronchopneumonia down here, or maybe even influenza related. Again, airway thickening and some opacities that seem to be clustered around the airways. But then when I looked up at the upper portion of the lungs, I saw that this patient also had a little peripheral ground glass opacity unassociated with airways. And what happened is this patient likely had pneumonia and was being treated for it, but also had been exposed to a family member who had tested COVID positive, and the patient was, I think, in their 80s. So we're not sure exactly whether we have cases of co-infection of COVID and other respiratory viruses or other infections, but of course the reports for these things will probably come out with time. What we do see classically with influenza, just as an aside, is that typically patients get influenza and then subsequently get infected with a bacterial infection. There seems to be a strong association. And I've heard that in previous coronavirus outbreaks related to, say, SARS, the original SARS virus, in subsequent years, the patients had not the patients, but those communities that were affected by SARS had much higher rates of flu infections. The implication is that the immune system or the local ability of the lung to fight off infection is affected by the current infection, meaning one infection depresses your immune response to subsequent infections. So this will probably be borne out in the coming years and coming months as a proper flu season comes later this year. Okay, let's move on to another slide. This is an example of pulmonary edema. Okay, and what are we seeing here? Let's see if I have no, I don't have that there. This is an example of pulmonary edema. We were talking about pleural effusions previously. What we see here are dependent pleural effusions as fluid. See an area of lung that is maybe consolidated, but in this case, the patient didn't have fever, and what we can see is the lung it looks like it's really being compressed by the fluid. Even better shown on the left side, where we have a big pleural effusion, and we have this lung that's being smushed together. Another sign or suggestion that we have pulmonary edema, the patient has a big heart. This is cardiomegaly. I'd call this moderate. Okay, with the bilateral effusions, because it's a bilateral process, and the compressed lung, we consider this to be pulmonary edema. So just because the patient shows up with shortness of breath does not mean that that patient has COVID. They may well be a standard patient who has cardiac history and triggered an episode of pulmonary edema. Maybe they ate too much salty food or had some other issues that caused that. Maybe they had a small heart attack and that produced this appearance. So very important to know what that appearance looks like on imaging. Here's the case where we have another sort of super likely influenza. This is a little bit more complicated because we have these little nodules, but I see that there are these septal thickening, these little lines that are thickened that outline some of those pulmonary lobules. And this is something where the patient may have superimposed edema or have a combination of effects. By no means are you guys supposed to make these diagnoses or associations. The point of these demonstrations here are to sort of open your mind and remind you that there are other appearances. And as you may see in this patient, oh, maybe this is COVID, but we see that the predominance of findings are clustered in one area. They may be bilateral, and that there seems to be edema or septal thickening, and those findings tend not to be associated with COVID. So even though I see bilateral opacities that are kind of ground glass in this patient, I find that the distribution is more airway associated, and that there is septal thickening that goes with that suggests edema, and so I would move away from COVID. Now, if I had no markers of flu, so say no flu positivity, no history of edema or administration of fluids, then I might say, okay, well, COVID is a possibility, and this is just an atypical presentation of that. If you see something that has some of the negatives that we talked about, negative predictive findings, then you should start to think about other options. Okay, don't just jump at everything as being COVID. How about this one? What do you guys see? Let me clear the poll. So put your answers in, okay? Good. Great. So I see people putting in some responses. Main response, the most common response, yes, most common response I see, and it's listed in blue, is PE. Also see something hypodense, hypertrophy, consolidation, pericardial, effusion, embolism, lobar. Okay, so let's go back for a second. What are we seeing? Let's look at the image on the left. Here we have ascending aorta, main pulmonary artery, branching into right and left main pulmonary arteries, and we have descending aorta. So orient yourself immediately. This is a CTA. This pulmonary artery is our densest structure because it's got contrast. We follow it along, and oh, lo and behold, we see filling defect. These are PEs. These are big PEs. Okay, now pulmonary emboli are important. Obviously, they can kill you, and they're very important. One thing I would like you to focus on is that as soon as you see a PE, no matter how big or how small, don't get hung up on the size of the PE, but think about what's the effect. And so that's why I'm showing you the second image, which is an image lower down on the same patient. And what we're looking at here is the heart. So let's orient ourselves. Left ventricle, right ventricle. This is the right atrium. We see a little bit of the left atrium. What do we notice about the relative size or diameter, cross-sectional diameter of the right ventricle versus the left ventricle? The right ventricle is much bigger than the left ventricle. It's almost 3 times as wide. Now, this is a CT of a beating heart, so we're not going to get the most accurate measurement. But what we can say by looking at this is that, hey, it looks like there's increased volume and probably increased pressures in the right heart. That may be attributable to the pulmonary emboli. One thing that I would like to point out here is that the size of the pulmonary emboli does not necessarily imply the degree of the effect. Remember that when you have decreased blood flow to a certain part of the certain set of you've decreased oxygenation to a certain portion of lung, and eventually decreased arterial blood flow to that certain portion of lung, there may be a vasoconstrictive response in that vascular bed. So a lot of what's happening in pulmonary embolus is not simply the mass effect of the pulmonary emboli, but the secondary hypoxic vasoconstriction that occurs in these patients. So the pulmonary embolus triggers a cascade of effects where it causes a little bit of a decrease of blood flow, decreases oxygenation in that region, increases hypoxic vasoconstriction, and altogether that net effect of the mass effect of the emboli plus the vasoconstriction leads to increased pressure on the right. Ultimately, what's going to kill these patients is going to be the right heart strain. If they cannot overcome this, their heart will go into failure, and then that's how many of these patients die. So when you see pulmonary emboli, as soon as you see them, no matter how big or how small, the next step is to say, hey, what's going on in the heart, and is this ratio normal? A way to simply think about this is that the left ventricle diameter and the right ventricle diameter should be roughly equal. Left ventricle might be just slightly bigger. This is not going to say 100% that the patient is undergoing right heart failure or right heart strain, but it's an implication the patient may have that process, and you should be looking for it. So here's an example, a good example of pulmonary embolism. And here are the responses that you guys put up here. Some of the things you mentioned that are not here, I don't see any evidence of pleural effusions down here. I don't see any pericardial effusion. I don't see fluid around the heart, okay? Here's another, here's the pulmonary embolism example. Here's another example of pulmonary emboli, and this is would be an example of a saddle embolus. Oftentimes, the pulmonary emboli are much, much smaller. You're going to see them much more distally, and really that's going to be up to your local radiologist to help make that determination. But again, what I want you to think about is I see pulmonary emboli anywhere. I want to look at the heart and see how that's doing. Okay, so in this case, we can see that the right heart is about double the diameter of the left heart. Okay, great. Here's an example of another process. A little bit more complicated. I'm clearing the responses. Why don't you guys try this? Here's the chest X-ray. We may see some nodular opacities. It's a younger patient, and then they come in, and when they get the CT scan, you can tell me what their likely risk factor is. You could also tell me what you're seeing. What do you see? Okay, great. So I'm seeing bilateral. I see some ground glass opacities, but also more importantly, I see somebody saying the word cavitation. I see emboli, septic emboli. These are the words you guys are putting up here. Let's show you. Bilateral opacities, good. Maybe some ground glass opacities, but very important is we see cavitation, right? Cavitation is there. And then the implication is this patient septic? Let's move ahead one slide. And this is an example of septic emboli. Let's talk about this. This is a younger patient. I think she was 33. IV drug use history. So she didn't declare it initially, but of course, when seeing this imaging, I asked the doctor, can you ask? Yes, she finally admitted that she had used IV drugs recently. We see some nodules that have cavities. There's a little bit of cavitation here. On this slice, we can see a little bit of cavitation here. If we rolled up or down, we can see it better. We see other nodules, and the definitive pattern here is that it's bilateral cavitary lesions for these patients. So the implication is that this is going to be septic, and likely be septic emboli. And there's a question: how do you know that this is septic? Well, it's a pretty characteristic appearance. Cavitary lesions tend to be associated either with septic emboli, particularly if they're peripheral and have this distribution. It's a little bit a finer point, but the distribution is such that it goes in a pattern that would fit where blood vessels would be. So if we think about the pulmonary lobule in that earlier diagram, the artery goes to the center of the pulmonary lobule. It doesn't go to the pleural margin, it goes to the center. And what we notice here is this nodule is close to the pleura but doesn't actually touch it. So it has what we'd say an arterial distribution, arterial pattern. Cavitation and the thickened rim is strongly associated with it. And then if we hear that they have IV drug use history, we're going to argue strongly for that as a possibility. Other things that cause cavities, obviously, you could have cavitary cancer. You could have tuberculosis that produce cavitary lesions. You can also have other infections that can do that. But what we're in this context, what we're thinking about, COVID or not COVID or influenza, we're not going to be seeing cavitary lesions in COVID. We're not going to be seeing cavitary nodules in influenza. We're not going to be seeing that in pneumonias. If we're going to be seeing anything that's sort of cavitary or necrotic in pneumonia, where we think about totally different types of pneumonia, say such as Klebsiella, I think, or Haemophilus, or Staph aureus. But remember, most patients, statistically speaking, if they're going to have a pneumonia, it's going to be strep pneumo as their most likely cause, or maybe they'll have mycobacterial mycoplasma pneumonia. For our purposes, if we see peripheral cavitary lesions like this, and we hear any history that supports it, like IV drug use or other injections, say maybe the patient is a dialysis patient who's getting who has a fistula, then we could say, hey, there's a risk here that the patient has septic emboli, okay, or basically infected emboli. Okay, this is just a last case I want to show you guys. Sorry, there's another question. The last case I want to show you is a motion artifact here. The reason I bring this up is that not everything that's ground glass is an abnormality. Sometimes it's just a reflection of what's happening with the technique of the CT or the X-ray. In this case, you can see there's a little bit of blurring throughout, and this patient was moving and breathing throughout, and we get a hazy ground glass appearance down here at the right lung base, maybe on the left. That all resolved when the patient had a repeat scan with a proper breath hold. There's an additional question here, is that post-influenza pneumonia can present with cavitary lesions, correct? I have to double check on that. Again, I'm not a chest radiologist, and I have to double check if that's the case. I have not seen post-influenza pneumonia presenting with cavitary lesions. However, it's something I can take a look at and follow up with you on an answer. I'm sure that there are case reports on it, but we're trying to talk about common things being common. So if we see cavitary lesions, we should be thinking about that are bilateral like that. We should be thinking about septic emboli. If we see peripheral ground glass opacities in a patient with high fever but no pleural effusions and no cavities, think COVID. If we see a lobar consolidation, think pneumonia. But we're trying to go common things common. If you hear hoofbeats, think horses, not zebras. But however, that does not say that it's incorrect to ask about these other things. And so it would be good to look that up. If you have that answer and you want to send it to me, please, by all means. And if I have time later today, I'll look that up and try to post a response. Okay. So here's just some couple final points on this presentation. I just want to talk about recommendations on imaging, and then I'll get to a question that somebody put up. The American College of Radiology, it's one of the major governing boards in radiology world, and so they put out a set of guidelines saying that CT should probably not use as a first-line screening tool to diagnose COVID-19. The idea being that we should be able to test with PCR testing, and that should be our first-line testing. PCR tells us whether the patient's sick or not with the disease, whether they have it or not. That's the number one thing. The problem that we have is that many places don't have adequate numbers of tests or don't have adequate numbers of rapid tests, meaning tests that come back in several hours as opposed to days. The recommendations were to use CT sparingly and reserve it for hospitalized patients who are symptomatic. That's why we're not going to be CT scanning asymptomatic patients unless there are other reasons. They also want to be sure that you use infection control procedures. They recommended using portable radiography, meaning portable x-rays, especially in outpatient settings. And the reason is that chest x-rays can be easily cleaned, and so you don't have to bring patients in and out of the rooms and potentially spread the disease process around. However, after they put out this initial recommendation, they said that some are using chest CT to inform decisions on COVID-19. Basically, what they're saying is that there aren't enough available PCR tests, and CT tests are a very sensitive measure and can be used to actually look for the disease. So they urge caution, but the bottom line here is that CT and chest CT is a big part of the determination, a big part of the is going to be a big part of it's going to be a big part of what we're going to be doing in order to make the diagnosis on these patients. So chest CT in some hospitals and some institutions where they have multiple CTs may become a frontline way to help evaluate for patients until they have enough rapid COVID tests. So if you are working with patients, you're taking care of them, and you're in a situation where you're like, well, I need to make a quick diagnosis and I don't have an available test, it may be a worthwhile decision to consider a CT scan. This is something I have not gotten an answer from, and I've asked a number of specialists, is in a situation where there are no available rapid tests to check for a patient, should we just be converting one of the CT scanners in a hospital where they have multiple scanners to a COVID-only scanner to just quickly assess these patients? That's something that is still, I think, still up for debate. Okay, there was a question from somebody that said, how do you determine between cavitary lesions and thickened airways? I'll go back just quickly to septic emboli. So if we see the septic emboli over here, it's a great question. It's like, how do I tell that this is a cavitary lesion, whereas this over here is an airway, maybe with thickening? Well, in this medial portion of the lung, in the right lower lobe, and the left lower lobe, we can see these airways in cross section, and we're very close. That's where the airways are bigger. But as we get further out, the airways are going to get smaller and smaller and smaller to the point we're not going to see them. And really beyond sort of the halfway point from where the hilum is, the mediastinum, to the lung periphery, we're not really going to see the airways anymore unless they're bronchiectatic, unless they're abnormally dilated. So if we see anything that sort of like an open space and airspace like this, that's not an airway. There's just no normal airway that's there. So either that's a cavitary nodule, which it is in this case, or if there was a sort of a linear, like a tubular structure that was dilated, then we could say that that's bronchiectasis. So that's how we tell, and it's by knowing our anatomy and knowing the size. For somebody like yourselves, it's really about knowing the anatomy and knowing about the distribution. For somebody like myself who does this for a profession, with time it just becomes automatic. You get used to where these things are, and you can make that determination. Okay, great question. Okay, I don't know if there are any other questions at this point. I just want to show you the takeaways again, and I want to point out something here. We're gonna put this presentation up, the recording and the slides, on a dedicated blog post page. I think that's the best way to distribute it. These slides are going to be very, very heavy, so I can't email them to you. It's something like 20 or 30 megabytes for sure. So the easiest thing to do is to post the slides, a PDF of them on that blog post. I've already set up a blog post to hold that. So in about an hour, these slides will be up there, and in about 2 hours, the recording that we had today will be up there. And anybody who's interested or missed this or wants to hear about it or just refer to it, go to this. And of course, if you just want to do the 1 minute version of this, go to the takeaway slide, either this first slide, this last slide, or the slide at the opening part of the presentation. I want to thank you guys for your attention, and thanks for hanging in there. I'll hang around for another 10 minutes or 5 minutes for questions. You can feel free to email me. You can also feel free to just to go through the chat. You can also contact me other ways. Okay, I'm going to stop stop sharing and stop the recording, but I'm still here to answer questions if you'd like.